Okay, so Bismillah ar-Rahman ar-Rahim. Masa al-Khair lakum jami'an. Good afternoon, everyone. This is Dr. Reem Al-Ajloni, the director of the Jordan Breast Cancer Program. Thank you very much for joining us today. This is the fifth and the last session of our introductory series on breast imaging. Thank you for attending the 5 sessions. I would like just to remind you that these sessions served as introductory series to our conference in 2022. This conference will talk about breast cancer screening, diagnosis, and early detection. We will be announcing more information about registration and abstract submission and participation early 2022, and we will hope we can see you there. Hopefully it will be face-to-face or blended learning conference, and we hope to see you all in 2022. I would like to thank all of our speakers, Dr. Yolisi, Dr. Otto, and Dr. Stavros, who will be joining us next year in this conference, along with many other experts and specialists from around the world, from the region, and from Jordan for sure. Today, this is the 5th session entitled as a 3D mammography in the screening and the diagnostic session. We have Dr. Pamela Otto. It's my pleasure to welcome you, Dr. Pamela. Dr. Pamela is a professor and chair of the Department of Radiology at the University of Texas Health Science Center at San Antonio. She is a fellow of the American College of Radiologists, and she's a fellowship-trained breast imager and interventionalist with a long experience in breast imaging. Dr. Pamela, we are happy here to have you with us, and the floor is yours. بدي أنوه شغلة بس بدي أنبه if you have any questions about any of the sessions or about the CME hours or the certificate, you can send to Dr. Mahmoud Luqdadi. Dr. Mahmoud is our colleague who joined you yesterday from the Jordan Breast Cancer Program, and we will put his email in the chat for everyone. If you would like to communicate with us, you can call or you can send an email to Dr. Mahmoud Luqdadi. Dr. Pamela, the floor is yours. Okay, I'll send over chat. I will remind you that if you have any questions, you can send it over the Q&A or over the chat, or you can raise your hand. And if you raise your hand, then you will get the access to the microphone to speak directly to the panelists.
Just getting to this beginning slide, I'm sorry. I can't hear you, so I hope you can hear me. So if you have questions, if you would just type them. I don't know what's wrong with my speaker. But anyway, it's such a pleasure to be with you again. I really appreciate it. Please excuse my scrubs today. I'm in clinic, so one of my partners is covering for me. Today, we're going to talk about 3D mammography in the screening and diagnostic settings. I'm not sure if you have 3D mammography or tomosynthesis, but it has been very helpful to us in our settings. I just wanted to show you just a history lesson. I'm old, so of course, I remember when we did zero mammography on paper, you know, with all the lights on. So what I did was I went through time. So huge hamartoma on 0. And then this is, you know, the analog mammographic images, another big hamartoma. This is taken just a digital mammography without tomo, and you can see the hamartoma, but this is the same patient with tomo, and you get better delineation of the margins and much more internal detail. So we've really come a long way from paper, analog, to digital mammography, and now tomosynthesis. So much progress. As you know, digital mammography is a single 2D image representation of a 3D object. So just one image through, so we get a 2D image. Breast tomosynthesis, or digital breast tomosynthesis, or also called 3D breast imaging, stacks 2D images. So it's much like a CT, you know, as they go through the breast. Or if you can remember back when you probably did tomo images of the kidneys, we would give them contrast and we would tomo the kidneys. So it's the same type of imaging as we go through the breast. And it really does increase conspicuity of lesions when they're in plane. And this is just an example of that. So this is the same patient. I think you would be very hard pressed to call any architectural distortion or any spiculated irregular mass in here in this dense breast. However, here it really stands out. You can see the central nidus and then all the spiculations and radiations coming out from it. So really does help when you're in plane to see these images. There are many advantages to tomosynthesis. They do increase cancer detection, 3.5% to 53%. Most people say it's around 30%. And it decreases recall rates, 15 to 37%, with a mean of about 20%. So when we talk about it increases cancer detection by about 2.7 women screened. And that's really across, you know, really pretty well all age groups and across all breast densities. So it works for all women. And it decreases the recall rate about 17 to 20%, and really across all age groups and all breast densities. And this was a report out by Dr. Storm in Lancet in April of 13. Tomosynthesis performs better than tomosynthesis or digital breast tomosynthesis plus full field digital mammography performs better than just full field digital mammography in all lesion types. And this was out of the Laszlo trial in 2013. They showed that you do better if you combine digital breast tomosynthesis with full field digital mammography. Tomosynthesis is fabulous for picking up architectural distortion and spiculated masses. You see architectural distortion more commonly on DBT than on digital mammography, but it is less likely to represent malignancy on tomosynthesis. So we pick up a lot more radial stars than we ever did with just digital mammography when you compare it to tomosynthesis. But tomosynthesis does decrease inner observer variability. It increases your confidence that you truly have a mass, and it improves sensitivity while it maintains the specificity in detecting architectural distortion. And this has been proven in double-blinded studies, and it achieves higher sensitivity for architectural distortion than full field digital mammography. Once again, another illustration. I think you would be hard pressed to really call architectural distortion on this view, but boy, it does stand out right here. You can see the central nidus and the spiculations. And once again, same thing. We showed this before. Same thing. It really does stand out compared to the other. Okay, so I'm going to just go into some cases. That's kind of the science behind it. I'll go into some cases. This was a 62-year-old female with a palpable mass in the subareolar region of her right breast. So in this area, she had a palpable mass. So you're looking very closely. You do see the increased density when compared to the other side. But when you do the tomo on it, what you can see, I'm going to use this one, my magnified view, you really can see the spiculations coming out from it. and it looks much more suspicious on the DBT than it did on the digital mammogram. So here it looks suspicious, but here it really does stand out as different and something that you're going to do an ultrasound on. So we did the ultrasound. It's a shadowing irregular mass with angulation going toward the nipple. You can kind of see it's going to going into the nipple on this ultrasound evaluation. And that turned out to be actually a infiltrating lobular carcinoma, no, an invasive ductal carcinoma, and it did invade into the nipple on final pathology. This is a second patient, 47-year-old female who came in for screening mammography. So on the CC view on the far left is digital mammography, and this is and then the second CC view is the tomographic image, and you can see on the tomographic image how much better this irregular mass stands out, and you get some of the radiating lines coming out from it. And then you have first your digital mammogram MLO view compared to the tomographic view, where you can see this mass very well with the radiations coming out from it. Very irregular mass. I think on the digital mammography, that could be an easy miss. This was non-palpable. But on the tomographic images, it really does stand out much better. Once again, of course, you're going to do ultrasound. This is the ultrasound of it. It's got the clip. We did a biopsy and put a clip in it. Very irregular hypoechoic mass with shadowing. You can see it's invading septal lines here. Very suspicious. I would give this a BI-RADS 5, and it was an invasive ductal cancer. Another case, 56-year-old female for annual screening mammogram. She comes in, she's got saline implants actually, and no problems. And so we have our non-pushback technique, and then you have the pushback technique. This was actually at first called negative, and I just happened to be reviewing the case for some reason. And I looked at the tomographic images and I was like, uh-oh, what's this? So you see this here, but look at it here. Look at those radiations coming out from this very irregular mass. Here it is here. Once again, you can see these radiations coming out. Not good. I did the spot, well, I usually don't do a spot compression view. Somebody else did the spot compression view, but once again, you can see the radiations coming out and the irregular mass. Ultrasound is very telling. Irregular hypoechoic mass with posterior shadowing. You've got your echogenic halo around it. This was biopsy proven invasive lobular carcinoma, grade 1. She's trying to decide whether or not she's going to have mastectomy or if she's going to have a lumpectomy. The MRI showed multifocal disease, so we're trying to convince her that she needs to have a mastectomy because the deformity in her breast would be outrageous if we tried to go for all the little tiny areas. So she'll probably get a mastectomy with reconstruction. This is another 57-year-old female who came in for screening mammography. This was her regular digital mammography, and you can see a little bit of distortion here. Don't see it as well here. However, on the tomographic images, you can see it very well here. It's very much architectural distortion. You can tell by the image here that it's in the superior area of her breast. So here's the superior area of the breast. You can see it not as well. It looks about like it did on the regular film, but here you can see really the irregularity of the mass. I don't think it's much better seen on your spot views than I saw it here. You're still going to do an ultrasound examination. And once again, it's an irregular hypoechoic mass with posterior shadowing. Certainly it's going to be biopsied. And it was an invasive ductal carcinoma. Next case, 63-year-old female, once again for screening mammogram. Now you can see her architectural distortion pretty well on the digital mammograms. I mean, it catches your eye. But on the DBT, it catches your eye somewhat on the CC view, but on the MLO view, it really catches your eye as an irregular mass, spiculated. Once again, she's going to get an ultrasound, and it was hypoechoic mass going through the tissue plane, so invading through the tissue planes with echogenic halo. And this was an infiltrating lobular carcinoma. As we've talked before, infiltrating lobulars grow along the normal architecture of the breast and are often seen as architectural distortion and can be hard to detect. And then another lady with architectural distortion on DBT. So you come in and you can, on this one, on the regular digital mammography in the left CC view, I don't really think you see anything abnormal, but when you go to the DBT, it really stands out here that there is architectural distortion in here. You can kind of see architectural distortion on the MLO view. However, it really stands out on your DBT right here. Certainly you're going to send that to ultrasound. So I sent it to ultrasound and ultrasound was negative. So what we did was we did a stereo biopsy of this because I couldn't see it by ultrasound. So I did a tomo stereo of it. So we use our tomosynthesis on our stereotactic machine and we found it. And this actually turned out to be a radial scar. So we do pick up more radial scars with DBT. I think more about a radial scar when I can't find it with ultrasound. You know, that becomes higher in my differential than if I can find it with ultrasound. Here's another 45-year-old lady who came in for her annual screening mammogram. You look in here, your eye kind of catches a little bit of distortion. It persists and is, I think, a little better defined here on your DBT. I don't think you would call it on the digital mammogram on the MLO view. However, on the DBT view, you certainly would. You see this architectural distortion with the radiations coming out, a little bit of a central mass. Here it is again, just blown up for you. Here we are. Ultrasound, you can see I use ultrasound a lot. Hypoechoic mass, invading the tissue planes. And this was an infiltrating ductal cancer grade 1. This lady just had a central lumpectomy, meaning they did go on and take the nipple because the radiations came so close to her nipple. The nipple was free on pathology of disease, but they took it because it was just too close on imaging. And then she actually got a tattoo for reconstruction and is doing well. So I just wanted to make a comment, and maybe it's just my personal thing about decreasing radiation dose, discomfort, and cost to the patients. If I see a mass or architectural distortion that looks real on the regular tomographic images, and I'm going to be working them up, I personally do not do a spot compression tomographic image first. I go straight to ultrasound. If the ultrasound is negative, then I might go back and do some spot compression tomographic images. But I feel like if it's real on those two tomographic images, I'm going to go straight to ultrasound. Certainly, if they have dense breast and I see anything that looks suspicious, I go to ultrasound. I don't rely on my tomographic images to make that decision for me. I may go back to it if I don't see anything with ultrasound, but ultrasound trumps for me. And I think that this is one of the positives for tomo, is that oftentimes on digital mammogram, you feel the need when you just bring them back to do a spot compression view to see if it's really real or not. Well, if on the tomographic images, you see it in 2 views, I think you can be pretty confident that it's real and you can go straight to ultrasound. So I use ultrasound a lot. I give my residents trouble when they get a spot compression view on something that's real. I'm like, you need ultrasound. That's going to answer your question. So, you know, if you think about it, try to save your ladies radiation dose, discomfort, and cost of an unnecessary spot compression view if you don't need it and you're going to do ultrasound anyway. Okay, done editorializing. I'm sorry, it's kind of one of my things. All right, let's talk about tomosynthesis and microcalcifications. DBT enabled the detection and characterization of microcalcifications without significant difference from full field digital mammography. The detection rates and visibility were good for both, without much interreader variability or differences. Diagnostic performance with DBT was as good as that of full field digital mammography, but there was a significant interreader difference was found. And I think really what it's saying is you can see microcalcifications probably just as well with both, with full field digital mammography and DBT. They say that DBT slightly is better at estimating the size, but it's slight difference in size. So both work well with calcifications, and but sometimes you can get a better delineation of what the calcifications really are. So this was a 2D image, the calcifications, you know, and then here's the DBT. You really don't see much difference. They're both heterogeneous. They're irregular. They're grouped, and you're going to put a needle in it. This is a case I had, though, that DBT really was helpful. So she had some indistinct grouped microcalcifications in here. You can just barely see them here. She kind of moved on my mag view. But when we went to the DBT, which you can see better on this next slide, look at that lovely delineation. These are definitely ductal dot dash calcifications. And then when you look at it, you start picking up, look at those irregular, small, irregular masses that are in here. I tried to find this with ultrasound and I wasn't able to, because I thought, well, maybe I could do an ultrasound biopsy, you know, looking more for the invasive component, but I wasn't able to. So we did a stereotactic biopsy of these. These came back as grade 2 infiltrating ductal carcinoma with DCIS. And she went on to have a lumpectomy. She was able just to get hormonal therapy and radiation therapy. Okay, now there are some disadvantages to tomosynthesis. There is a mild increase in dose, but if you measure that against not needing to get extra spot compression views or the decrease in recall rates, it probably comes out about the same. We have not really answered the question, does DBT decrease mortality rates over full field digital mammography screening? So the TMIS trial is looking at that. There's been ongoing recruitment into that trial, I believe, for 3 years now, maybe 4. So hopefully we'll be able to answer that question. You know, I wonder, and literature suggests that possibly in very dense breasted women, automated whole breast ultrasound might better improve outcomes. The literature does support, though, that whole breast ultrasound, whether or not you do it automated or you do it with the tech, doing the ultrasound, really the outcomes are about the same. It's just if you have your tech go in to do a ultrasound of the bilateral breast and really do a good job of it, that's going to take 30 minutes compared to automated, which takes 2 or 3. So, it's just a matter of utilization of your machines, and do you have time to be doing a bunch of whole breast ultrasounds. There's a literature out that shows whole breast ultrasound does increase detection of cancer in high-risk women, with approximately 2.3 to 4.2 cancers per 1,000 women screened. And as I talked before, if you have high-risk women who will not get an MRI for whatever reason that they won't get it, I find ultrasound to be really helpful. And it's right there in the clinic, so I can just say, okay, move them to the next room and do the ultrasound. Another disadvantage to tomosynthesis is the storage of images. It takes a lot of storage in your PAC system. And then, of course, the cost. It costs more for both the patient and for you to buy this equipment. So, some people are very tomo positive and are like, oh, throw out all just digital mammography machines. I think it's a little early for that. I'm blessed to have the tomographic images, but I wouldn't say that full field digital mammography isn't good. I would say full field digital mammography is very good. Tomosynthesis does add another tool to the toolbox, and I'm happy to have it, but I know I'm blessed to have it. So are there any questions? And if you have questions, if you would please put it in the question and answer thing, and I'll try to see if I can get it. Okay, I see one here. I'll just read it aloud. Regarding the radial scar case, why didn't I do an MRI before the biopsy? The reason I didn't do an MRI is that independent of what that MRI showed, I'm going to do a biopsy. So if I find something that I'm going to do a biopsy on, period, I don't use MRI to help me decide whether or not I'm going to do a biopsy. This had enough mammographic findings that I'm going to do a biopsy. And if it turned out to be an infiltrating lobular, or she's dense breasted and I wanted extensive disease, then I would do an MRI, but not before the biopsy. Any other questions? I know I kind of went through that fast, but can I say, how long is the learning curve for reading DBT? I'm going to tell you what, it is a very fast learning curve. In the States, you have to take, a certain number of hours of training in it before you can charge for it. I think it's 5 to 8. I can't remember exactly. So I took my 5 to 8 hours of training in it. And, when you first start going through the tomographic images and you're scrolling through them, you're going to be a little slower. So, maybe the first, 2 weeks, you might spend 4 minutes per breast doing your DBT. But then after that, you're going to spend maybe a minute per breast doing your DBT. You kind of get where your eye catches those abnormalities, just like in mammography. At first, when you started, it took you forever to look at a mammogram, but then you get pretty fast in a while. So the literature supports that it takes about twice as long to read your full field digital mammography plus your DBT than just your full field digital mammography. And you catch on pretty quick. Okay, it says the optimum time of MR after biopsy. We do ours pretty quick, unless of course they have a huge hematoma. If they have a huge hematoma, we might, wait till the hematoma resolves a little bit, but generally we get them, especially if they're cancer patients, we get them within a week or 2. Let's see, is it right to do the screening with tomosynthesis only without the 2D images? I don't think anybody does that. I've not heard of anybody doing that. So I would probably say no, but that's because I've never heard of anybody doing that. And so I wouldn't want to be the first. And I haven't really looked at the literature to see if anybody is. Okay, so I like the next question. Can 2D plus ABUS be equivalent to DBT? I think that would be a wonderful, wonderful research project. I haven't read the literature on that. I mean, I use whole breast ultrasound a lot on my dense breasted women who are at high risk. If they've had 2D or they've had 2D with DBT, I use ultrasound a lot. So I've not read up on that, and I'm gonna have to get back with you. I'll have to look that up. I'm sorry, I don't know the answer to that. Going to the next question. If you don't find an ultrasound correlate to distortion seen particularly on tomo, would you do a biopsy then? Yes, I will. I'll do a biopsy with stereo because I've not done the study to say if it doesn't have an ultrasound correlate, I don't need to do a stereo. So I would do a stereo. All right. With dense breast, can we do the other position with tomo? Okay, I'm not sure. With dense breast INCC, can we do the other position with tomo? I'm not sure what you're asking there. If you could, Dr. Zoran, if you could maybe ask that in a different way. I'm sorry. Okay, here we go. Role of AI in 2D and 3D, your experience. Okay, so it depends what you're saying about AI. So we use the CAD system in 2D mammogram and have been using that since I got digital mammography. I find it helpful, especially during a long day. You know, sometimes you need a little wake up, like, oh my gosh, how did I miss that, right? It keeps you on your toes. So we use CAD a lot. The things that I've seen more recently in AI and machine learning isn't much different than what they're doing with CAD. So, but I do use CAD on all of our imaging, but I'm not buying it for 3D yet. I haven't seen the literature that supports that. So breast hamartomas can grow rapidly within 2 months and occupies the whole breast. I've never seen that. I've never seen a breast hamartoma do that. That would be a very interesting case study. You know, I mean, you hear about phloides doing that, but I really haven't seen a breast hamartoma do that. I've seen the examples I gave, especially the first two, those hamartomas, they had such significant differences in the size of their breast, you know, left to right. And one of the women actually did have her hamartoma removed just for symmetry in her breast tissue. But I haven't seen the hamartomas grow rapidly like that. Okay, so the next one is the CC view tomo better than the MLO tomo? They're both helpful. So we get tomo on both. We don't just get it on one, we get it on both. Okay, do I spot compression in 2D or tomosynthesis if the distortion is seen more in tomosynthesis than 2D? Okay, so like I said, if I see distortion in 2 views on tomosynthesis on the primary image when they come in for their screen, I go straight to ultrasound and look at it. If I don't see it by ultrasound, then I'm going to come back and do a spot compression tomosynthesis image. You know, so, but I feel like if I see distortion in 2 views, it's real. And I'm going to go with it. So I wouldn't do it. I wouldn't do my spot compression in 2D if I saw the distortion on my tomo images straight up. Okay, let's see here. Sorry. In one position, we see dense breast. Can we go for tomosynthesis in the other position? Like I said, I do tomo in both CC and MLO projections on all my patients. Oh, that was nice. Thank you. Your input on male breast cancer with no discernible lesion. Okay, so on men, we don't use tomo. If we think on the primary mammogram that they get that it is suspicious, we go straight to ultrasound. We don't really feel a need to do tomo. Okay, automated breast density softwares. I haven't used those. I don't see a need when we just put them in 4 quadrants. So I don't use any of the automated breast density softwares, and personally don't see a need for them. Then the next one, do you recommend MRI to explain to solve unexplained findings on DBT? Generally not. And generally I don't use MRI. I can, if I see it and it looks suspicious on DBT, I'm going to biopsy it. If it doesn't look suspicious, or it looks, probably benign, I'm just going to follow my usual stuff. I'm not going to send them for an MRI to help me decide whether or not I'm going to get a biopsy. I just go for it. And then if it's cancer, I'll get my MRI if I need it. Okay, is there any other questions? I'm sorry I can't hear you guys, but I feel kind of weird not being able to hear you, but is there anything else? Or ladies, I shouldn't say guys, I'm supposed to say persons these days. So anyway, any other questions?
Yes, doctor. There's Dr. Adnan, you are raising your hand, but unfortunately, Dr. Pamela can't hear anyone. So it's either you ask to us and we ask her, or you send it over chat, please.
Do you know what
Dr. Adnan, can you hear me? Because you are raising your hand. So please, if you have any question, please, if you can send it over chat. Because Dr. Pamela can't hear anyone.
Okay, I can answer these through chat if that's okay. I'll go back through these. Let me see. Here, I'll go back where I got a couple questions by chat. Let's see. Yes. Thank you for letting me know you could hear me. Okay. Could tomo replace 2D for screening, or should both be used? So we use tomo, well, for both. So we don't do tomo without 2D. So I think I answered that earlier. Let me go down. Do you still advise surgical excision for radial scar, or is vacuum assisted biopsy sufficient? In our experience, if you get a vacuum assisted biopsy and you get plenty of tissue and there is no atypia associated with it, we're happy to follow a radial scar. So we don't always get a surgical excision on a radial scar. Let's see. If the patient presents with a right palpable abnormality and mammo is inconclusive, do you give it a 0? Actually, if they come in with a palpable abnormality, they're not a screen. So they're going to be a diagnostic, and we're going to go on and get an ultrasound and come to a conclusion on what we think. So it wouldn't be a screen. So I'm not going to give it a BI-RAD 0. I'm going to work it up completely. And I'm going to give it either a 2 if it's a simple cyst, 3 if it's something like looks like a fibroadenoma, 4 or 5 based on what the ultrasound shows. Is it suggestive of malignancy or highly suggestive of malignancy? Okay, let's see. Okay, no, I guess what I'm trying to say is for all patients that come in, we do bilateral CC MLO views with tomo, and then, you know, we back process that to the 2D images. So I don't take a 2D image and then the tomo. I synthesize the tomo back to a 2D image. So it's a synthesized 2D image. I don't take the 2D and then a tomo. I just take the tomo and synthesize back to the CC and MLO view. Some people do both, but we take the synthetic views for our 2D views. The FDA has said that those are fine, and we're going to go with science. All right, let's see. In a patient with a palpable abnormality, how appropriate is MRI as solving modality? Do you know, I have rarely used MRI to help me with those things as far as a palpable abnormality. If I do a mammogram and an ultrasound over a palpable abnormality and I don't see anything, then I just follow them up. I don't send them for MRI. Now, there's the caveat. I tell somebody there's nothing here. There's nothing, right? And then they just can't sleep at night. And if their insurance will pay for it or they'll pay for it, they can get an MRI, but I don't recommend one. I just generally don't recommend one. So I think twice in my career I've done it. So and I've been doing it 30 years. So not very often. Okay. All right. I think I've answered all the questions in chat. Oh, here's a call. Let's see. Let's see. What about, okay, here's a question. What about asymmetry and focal asymmetry in tomosynthesis? How do you deal with them, and when do you do spot compression? Okay. If I have a focal asymmetry, meaning you see it in two views on tomo, they go straight to ultrasound. If I just have an asymmetry, meaning it's only seen in one view, then I might try a spot compression tomographic image first. Okay, I probably would. All right, so focal asymmetries in tomosynthesis, I consider them real, and I don't necessarily do spot compression. But if it's just a asymmetry, meaning it's seen only in one view, then I'll do a spot compression tomo. And then do we do risk assessments? Like I said, we kind of use the Gale model here, primarily based on family history and personal history. If it gets much more complicated than that, we send them to a genetic counselor. I know that I'm very blessed to have, I have 2 genetic counselors that we can send them to. So I'm very blessed to have that. Okay, is there anything else? Looking, open, answered. Okay, I'm going back to chat, see if there's anything new in chat. I think not.
Yes, if you have any more questions, just send it over chat because Dr. Pamela can't hear anyone. Other than that, let me just check, Doctor. We have no more questions. On behalf of everyone attending, I would like to thank Dr. Pamela Otto. I would like to thank our speakers who were with us over the past 5 days with this introductory series on breast imaging. Again, thank you very much for joining us. Thank you for being for us for the past 5 days. The number we started in the first day is the same number as now. So we are so happy, extremely happy that you have joined us, that you, we hope that we have delivered good messages or refreshed your knowledge on breast imaging. We hope to see you in 2022 in our conference in October 2022, which will be about breast cancer screening, diagnosis, and early detection. And our speakers, the 3 of our speakers, Dr. Otto, Dr. Yerisi, and Dr. Stavros will be joining us at that conference. Thank you very much. I hope October is approaching us. October, the International Month for Breast Cancer Awareness. We hope that you will be our advocate in the field. You will be the champions of early detection of breast cancer, as we deserve that. I think every woman in Jordan deserves that, to have equal access to affordable and high quality early detection services across the country, and to have all of the cases in early stages, hopefully. Thank you very much again, Dr. Otto, and we will see you again soon. Shukran jazilan. Again, if you have any other questions, please send it to Mahmoud Maqdadi, to Dr. Mahmoud Maqdadi from the JBCP team. His email is in the chat. And thank you very much. Thank you. By this, I'm concluding. Salam, Dr. Pamela.